This is week 7, lecture number 4. Namaste. In this week, we also studied about how to prescribe ENDs, essential narcotic drugs. Again, we are emphasizing this subject because safe prescription of essential narcotic drug is our moral responsibility, and if it is prescribed safely, your patients also will be benefited with good pain relief without causing any adverse effect or side effect of the drug. So, few of the slides may be repetition or content may be repetition of the previous subject, but this is we want to emphasize that how to use ENDs safely. First and foremost, the purpose of this lecture is to lay down guidelines for opioid prescription. There are each and every department should lay down a guideline whenever you are prescribing ENDs or opioids to your patient. The certain guideline needs to be followed. So, this guidelines is for the cancer pain management and breakthrough pain management, how to do opioid rotation from one opioid to another opioid, how to convert from oral to the transdermal opioids, and how to manage opioid induced side effects. So, all the guidelines should contain all these points in detail. Secondly, the purpose is also to make clinician aware about the NDPS amendment. NDPS Act, it is a Narcotic Drug and Psychotropic Substance Act. It was introduced in clinical in India in 1985 and then amended in 2015, which is a very important amendment as far as palliative care physicians are concerned. And all clinicians who are practicing palliative care or who are going to subscribe narcotic drugs to the patient should know about this NDPS Act and its amendments. The scope of this guideline is also to standardize prescription of opioids across the hospital service. It is not only restricted to your department, but even other department who prescribes opioids should follow this guideline. And to prevent and actively manage the opioid related side effect, the main focus of the guideline can be extended by even management of its side effect and prevention of the side effects. So, when you are managing pain in long term pain means chronic pain, usually observed in cancer pain, HIV patients, and few of the non-cancer patient also has a chronic pain like low back pain, shoulder pain, cervical pain, etc. So, here the goal is to reduce the suffering due to pain, improve the functionality of the patient and improve the quality of life of the patient. So, whenever you are using opioids for long term, for many months or even years, many of our patients are on morphine or other opioids for 1 year, 1.5 years. So, what are the best practices? For patient with mild to moderate pain whose pain is not controlled by non-opioids given orally and regularly, low dose step 3 opioids should be started. So, oral morphine less than 30 milligram per day may be used alternatively instead of codeine or tramadol. Sometimes step 2 drug like codeine and tramadol. Codeine is a very good analgesic, but severe constipation is noted with codeine, and nowadays it is not available except in the syrup form for cough syrup and all. That too they are misusing for addictive purpose. Tramadol available across the counter, but it does have side effects like irritation, gastritis, nausea, vomiting. So, you can use, instead of these, you can start morphine less than 30 milligram per day. Immediate release and slow release oral formulation of morphine, oxycodone and hydromorphone can be used for dose titration. Other these two drugs are not available in our setup. The titration schedules for both types of formulation should be supplemented with oral immediate release opioids given as needed, and transdermal fentanyl and buprenorphine are alternative to oral opioid. As I said, patients who cannot swallow, we can put them on transdermal fentanyl. Of course, it is very costly drug, many of our patients cannot afford. Buprenorphine tablet, buprenorphine is alternative which is available in Indian market. It has its own limitation. After certain dose, you cannot increase the dose because it will not be effective in giving pain relief to patient. So, it has got a ceiling effect because it is partially agonist and partially antagonist against the morphine receptor. After certain dose, it will not be effective. Secondly, incidence of nausea, vomiting is also reported. Of course, it does not have much constipation with whenever you are using buprenorphine. Either drug may be preferred step 3 opioid for some patients. For patients unable to swallow, they are an effective non-invasive method of opioid delivery. So, patients who are not able to swallow, you can give transdermal fentanyl, or buprenorphine can be given sublingually. This we discussed in previous lecture on WHO ladder, always to be drugs to be given by mouth, by cloak, by ladder, attention to detail and individualized treatment. How does one start oral morphine? Start with immediate release, quick release, then switch over to constant release. One thing about constant release tablet means morphine SR tablet, you should remember that it should not be crushed. Most of our head and neck cancer patients are with Ryle's tube. So, we give immediate release tablet which can be crushed, mix into the water and give it through the Ryle's tube. But this sustained release tablet cannot be crushed, it will lose its effectiveness. So, patients who are on Ryle's tube and who are given tablet in crushed form, they should not be given sustained release tablet, they are always put on the immediate release tablet. So, initially you can start with a immediate release tablet every 4 hours and increase the dose 5 milligram at a time till the pain is relieved, and rescue dose means ki for breakthrough pain, intermittently patient get sudden pain, you can give extra dose of morphine. Again we discussed this, that counseling of the patient, explain each and every medicine properly with timings, with its side effect, and what are the changes patient should bring in the diet and lifestyle when they are on morphine. How to start sustained release is like converting immediate release dose multiplied by 3 is the sustained release dose. So, breakthrough pain dose is 4 hourly dose of the morphine. So, if patient is on 10 milligram 4 hourly and he gets intermittently very severe pain, one extra tablet of 10 milligram he can take during that time whenever he is getting a pain episode intermittently. Principles of opioid maintenance therapy. So, maintenance you can switch over to extended release. Rescue dose is always prescribed. Rescue dose is always immediate release tablet because it has to act very fast. Patient just got up from the back and he strained his back bed, he got up from the bed and he had sudden pain in the back because of the vertebral metastasis. That time he can again sit down, take one immediate release tablet, one extra tablet of morphine, and his pain will be relieved within 20 to 30 minutes. So, any time when you want to increase the dose, it should be 33 to 50% increase from the previous dose, and fentanyl should be used only in opioid tolerant patients, means patient who are tolerating opioids properly, they will tolerate fentanyl. Otherwise, fentanyl also causes lots of nausea, vomiting. Before prescribing fentanyl, one should keep in mind that patient's pain should be adequately treated or controlled by morphine. Then the same dose can be converted into fentanyl patch. If the pain is poorly controlled, it is given for the stable pain. If pain is poorly controlled, fentanyl will not act. So, if patient's pain increases day by day, the fentanyl patch will not act, because once you apply the patch, it will act for 72 hours and you cannot change the dose. In that case, intermittently again you have to give morphine along with fentanyl patch to relieve the pain. Specific indications for the fentanyl patch are the patient who cannot swallow, who has got poor compliance to the tablets. Many of the patient does not like to swallow tablet. So, or they have plenty of tablet to swallow, then by giving patch you can reduce few tablets, which spare few tablets which he does not have to swallow. So, poor compliance patient, patient with renal failure in which morphine action can be prolonged, you can prescribe fentanyl patch. Then patient having severe constipation with morphine or severe nausea, vomiting, hallucination, in this patient you can switch over to fentanyl patch. It is too costly, about 125 microgram patch costs about 550 rupees, but of course it action lasts for 72 hours, means for 3 days. Where you should apply fentanyl patch? This is the training, it should be given to the all nurses in our setup. Wherever in whatever hospital we are using fentanyl patch, all nurses and all doctors, paramedical staff should be given how to apply fentanyl patch, because they feel the patch should be applied on the area where there is a pain. Here it is wrongly applied on the nipple. So, it should always be applied on the flat skin, dry skin and skin without hair. It need not be applied to the area where it is pain. It can be applied any other way, like on the front of the chest, on the side of the arm, back of the chest or back of the lumbar region, in the back, on back side of the lumbar region. So, this is the way you should apply the patch. Tramadol and morphine, there is no comparison. Tramadol is a weak opioid, morphine is a strong opioid, definitely more potent and very highly effective in cancer pain management. Whenever a patient is given morphine, how you will monitor them? First of all, is analgesia satisfactory, means you are giving adequate dose of the morphine? Does after pain relief patient's activity has increased? Have we achieved the balance between pain relief and adverse effect? His adverse effects are under control, like constipation is manageable, nausea, vomiting is manageable, he is not too sleepy, he is able to do his routine and all, or whether is there any abuse potential. So, every time he comes, you check how much morphine he has taken, has he taken extra dose of morphine, are there any missing pills, has his pain is stable, or is he taking morphine from some other prescriber. All these things you have to evaluate to check on the abuse potential of the patient. How you can detect the potential addiction potential be detected? First of all, opioid checklist, which is this is filled up during the first visit of the patient, and by tools, as I had said in previous lecture, that by using the tools and this questionnaire, where there is a history of family addiction in family, alcoholism, illegal drugs, prescription drugs, alcohol abuse, illegal drugs वगैरह, all this history needs to be taken and given a score. How do we assess the patient's adherence to prescription? First, check whether patient is taking morphine from only one doctor and one designated pharmacy and not from the multiple prescription. Monitoring program, where you have to pill count. You have given 100 tablets of morphine to the patient. When he comes back, exactly how many he should, suppose he comes back after 15 days, how many tablet he should have used, how many should be remaining with him, where are the empty wrappers, and also things are the, it is called prescription monitoring program. Double check on the stolen medicine. If the pills are missing, check with the relatives, check with the patient, check with the patient's family doctors or any friend in the in his group. Lastly, urine analysis can be taken up, which will measure the morphine into the urine. If he has taken very large dose, it can be detected in the urine test. This is how we write the prescription of the morphine, like tablet morphine 10 milligram, immediate release, 1 tablet 4 hourly, right. Then we write 1, 1, 1, 1 and night 2 dose, the middle of the night dose is combined over here and the last dose. Here we write timings 7 am, 11 am, 3 pm, 7 pm and 11 pm. Then if suppose we are giving it for 15 days, here we write the number of tablets, like for 15 days it will be 90 tablets. This is the complete, and with this you have to write tablet bisacodyl 5 milligram, 2 tablet at night. Suppose for 15 days means 30 tablets. This is the way we write the morphine prescription. So, number of tablet has to be written. So, the pharmacist also counts the tablet and gives it to the patient. Which are the aberrant behavior? Patient keeps on asking for morphine frequently, frequent visit to you, then there is suddenly he instead of 1 tablet he takes 4 tablets 4 hourly, repeated visit, approach to other doctor, we come to know from the pharmacist, we come to know that he has come very frequently to take the medicine and all such things. So, these are the symptoms which causes shows aberrant behavior. On long term adverse effect, very few adverse effect has been noted, which can be severe constipation with fecal impaction, dryness of mouth, tooth decay, increased incidence of fall and dizziness, hypogonadism, increased pain sensitivity and sleep or disorder breathing can be detected in this patient. So, again we are emphasizing on evaluation of the patient, consider alternative whenever you are in suspicious of that patient is not using their morphine properly. Discontinuing opioids may be difficult, explain to the patient, then you have to taper off over a period of 10-15 days, then it can be discontinued. Take time to talk clearly and screen patient for depression and other psychiatric disorder before starting opioids. do not give opioid to relatives. First time at least patient should be seen by you, evaluate the patient and just do not give away with any other person. So, evaluation of the patient, do not start opioid without evaluation. Opioid rotation, you should have some alternative opioid available. Otherwise, do not continue opioid in patients who show no progress toward treatment and goal is opioid rotation. Do not assume that patient knows how to use opioid. You have to tell them each and every steps. Always trust the patient, but always verify in your own way whether he is using morphine properly. So, here we talked about CR and SR tablet should not be crushed. This was amended in 2014 and there and in this amendment it was introduced essential narcotic drugs, which has got uniform law, central law as far as prescription, procurement and sale of this END is concerned throughout India. So, if you have proper guideline, it is safe to use narcotics. You should have knowledge of NDPS Act and you should have knowledge of how patient behaves when they are on morphine. And it is responsibility of all treating doctor or prescribing doctors to check repeatedly that the morphine is used properly for pain management and not misuse or abuse by patient. So, it should not be misused by patient and should be used properly by for pain management only. Thank you very much.